So you got it, okay? You got the fact that this is serious. Now, if you look under central lines, the key for the central line is that the tip is going to sit where? In the vena cava is the proper response to that question. It's going to sit in the vena cava. Now, don't sweat it. It's on the next page. Right now, I want to point out that this actually has to be confirmed with an x-ray. You see that? It's in big capital letters. We use it under bullet point number 2 for chemo, TPN, ABGs, arterial blood gases, hemodynamic monitoring, vesicant drugs, blood draws, apheresis, and a bunch of other crap, right? So we love them. But they are what we would call, if this happens, you have to watch for a CLABSI. Central line associated bloodstream infection. That is a quality issue on your unit. CLABSI. Central line associated bloodstream infection. Now, if you look at it under where it says confirm placement with x-ray, you'll see it says scrub the hub for how long?
15 seconds.
That's on your test. Scrub the hub for 15 seconds. You need a bio patch with a 360-degree contact with the catheter. That's the dressing we use with the bio patch. You change the dressing with any soiling, and some units will say every 48 hours. You need a 10 cc syringe to deliver medications through the central line. If you use a syringe too small, you'll cause an embolism. If you look at the next page, which talks about central lines, you will see the complications include air embolism, pneumothorax, that BSI should say CLABSI if you think about it, and thrombophlebitis or DVT, or air embolism. If the patient is just getting their central line inserted, they're going to need to have on a mask and a bonnet, and the person putting it in will need a mask and a bonnet. And we will lay them back for insertion, and we will want them to hold their breath. Now, don't get crazy with that, just understand it. If they don't and they take a breath, that could be why they got an air embolism. Okay? All right, now, you will see that it says right where the word remember is, that's where I want you to highlight. Remember that the tip of the CVC sits in the superior vena cava and needs to be confirmed with x-ray. You cannot use it until it's confirmed. If it's peripheral, it's called a PICC line, right guys? What's the worst place for a central line? Where don't you want to put them? I meant what I said. Where don't we want to put them?
You don't want to put it in the arm, maybe down the leg.
What is that called, nurses? Y'all using all this stupid ass language. Say it again. Femoral. That is the worst place for a central line. Femoral site. Why? Infection. That's your groin. Hello. That was on the test. So if you look at the top, it says it can be peripheral, jugular, subclavian, or femoral. It says right on there, last resort. Everybody see it? It's in the bold print in the first paragraph on page 4. It says right on there, last resort.
So if you have to, you have to.
You have to. But you don't see it very much because we don't have to. It's the worst place because it's the groin, incontinence, all this nonsense is down there by your central line. Now, you already see all the specifics. You don't need to worry about any of it except do this for your girl. Everywhere you see tunneled or non-tunneled, highlight the word itself. So in the triple lumen, highlight non-tunneled. In the PICC line, highlight non-tunneled. Understand that a TPN has to be given through a central line. And I want you to put a star by TPN. It's the source of a lot of questions. It was on, I forget what it was on, but it was on television. It was on some kind of, well, it probably was on Grey's Anatomy because that's what I watched. So the TPN must be a central line, and they're gonna ask you what should the nurse monitor? And you should monitor 3 things. They're all together in the second bullet point. Glucose, white blood count, and albumin. Those are the 3 labs. With TPN. It's a very, very, very critical solution. You have a lot of work to do. We usually monitor blood sugar every 6 hours. Because the TPN can raise your blood sugar because it's so sweet. So the problem with that TPN being so sweet, bacteria love sugar. So TPN is very sweet. You're monitoring the blood sugar every 6 hours, but you're also understanding that because it's so sweet, it's a high risk for infection. And if you get that kind of infection, where's the tip of this central line? In your heart. Okay, so that's one. Then albumin. Can someone tell me why I'm monitoring the albumin level? What lab is albumin for? What does it tell me about you? Your nutritional status. What do the letters TPN stand for? Total parenteral nutrition. If I gave you a TPN for nutrition, shouldn't I monitor your nutritional status? That's the albumin. Now, I always tell you to remember albumin like this. You pretty much used to hear all your life, you got to eat 3 meals a day plus snacks. Well, albumin level should be 3 plus snacks, so 3.5 and up. You see that? Okay, that's a good way to remember albumin. Now that's your TPN. That's a big deal. TPN's a huge deal. Now we have something called PPN. What does that stand for? Who is it for? There's a fancy word on there. How do you pronounce it? Cachexia. That fancy word is cachexia. Do you remember the word anorexia? I tell you it's cancer's anorexia. Cachexia. Cancer's anorexia, cachexia. Now let's make sure we understand this. I've often told you that sugar is the devil. Told you that yesterday, tell you that every damn day. Well, there's no greater proof than the cancer patient, because cancer cannot survive or grow without sugar. In fact, one of our experimental treatments for cancer is keto diet. So when you have a patient who has advanced cancer, the classic hallmark sign is that they lost a lot of weight, because you can't eat enough sugar for that much cancer in the body. It's spread all over. And the cancer in the body that is spread all over and is aggressive is eating up your fat, because sugar is stored in the body as fat. So once it chews up and eats up all that fat, it gets a lot of sugar. Now you have cachexia. You are emaciated because your body is riddled with cancer, and it's growing quite well off your fat. That's why obesity is a risk for cancer. You gotta understand that relationship. If you did, you'd stay away from sugar quite a bit, especially when you get old like me. You're not scared yet. You gotta get over 50 and see some shit first. Okay, so you got it. Now, the Hickman and the Portacath, or your ports, you must highlight tunneled. They are not untunneled or non-tunneled. They are tunneled. Which one is at least risk for infection? I'll come around. Is it the tunneled or untunneled? I'm asking you.
It's a
Tunneled? Which one's at more risk for infection?
Oh, more risk is the
Tunneled or
untunneled.
Untunneled? Okay. Non-tunneled? Non-tunneled? Tunneled? Non-tunneled? Non-tunneled? Tunneled? Non-tunneled? Tunneled? Non-tunneled? 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 Tunneled? Tunneled? Tunneled. The question was, which one's at risk for more infection? It is the non-tunneled. Because if you put it in a tunnel, infection can't get to it. The non-tunneled is at very high risk for infection because it's open to the air. So I want you to say to yourself on the test, because it's going to ask you that, think it's all buried and tunneled, it's not at risk. It's like you can't get to it. My hands can't get to it. Yeah, so it's probably confusing the way I asked it, but whatever. Just remember, everyone, tunneled is least likely to get an infection because it's covered up. Yep, it's all covered up. The non-tunneled is open to everything, child. Okay, so you're going to be fine. Now, look at what I wrote about dialysis. I wrote central lines for dialysis. Remember that the red port is arterial, just like your books back in the day. The blue line is for venous. There's something called a permacath. Uh-oh, what is it? Tunneled. Color it, highlight it. You know you got to color anything that says tunneled or untunneled. For hemodialysis or apheresis, a lot of patients will get a temporary catheter called a Quinton catheter, and highlight that, because what is that? Non-tunneled. It is short-term use for hemodialysis. My favorite line for dialysis is this trialysis catheter. Do you see it? The tri means 3. So you basically have a triple lumen. You got the red, the blue, and the purple. The purple is for contrast dye, infusions, medications, blood draws, hemodynamic monitoring. Please write where I gave you space in big capital letters. Never draw blood from the dialysis site. The only time you can draw blood from a dialysis site is if you have a trialysis. And that's not that common. But boy, is it my favorite. Okay, page 5. So, oh, that's a good question. So if you have a port, I can't see any tubings unless I access your port. It's underneath there. It's tucked away. I can feel it, but I can't do anything with it unless I access it. Then I can see catheter coming out. When I de-access it or take the needle out, it's still there for years. And it's still there for me to do stuff with. But it's tunneled. There's nothing coming out of it. It's buried surgically in the skin. And that's another good question, because remember that if it's tunneled, it was surgically placed.
Okay, tunnel is surgery place.
Yeah. You can kind of see it on some people, but most people with a port, you had to tell me you had one. And then I'll feel for it because I have to access it when I'm giving you an infusion or getting you ready for a procedure. I have to access it with the Uber needle. And you'll see that all through here. Okay? Now, the anesthesia and analgesia is on page 5. You don't have to spend a lot of time here, but I want to give you the bottom line. First of all, when it comes to anesthesia, you want to look at the anesthesia as having one big side effect, no matter which one it is. Does anybody know what the number one side effect of anesthesia is? Hypotension. Low blood pressure. Put that at the top. Number one side effect is low blood pressure of all anesthesia. Because of this, we preload the patient with 500 milliliters of fluid. Please know that.
You said 500 milliliters?
Yeah, we hydrate the patient ahead of time. In other words, we know that fluid increases blood pressure. So we preload them with 500 milliliters immediately before they get the anesthesia. With general anesthesia, you know the risk is, and look at it, I wrote it, malignant hyperthermia. This is genetic. That question that you ask the patient, I already wrote it for you. It is to ask the patient if they have ever had anybody in their family die in surgery or immediately after. Everyone see that? If the answer is yes, you better find you an anesthesiologist and make sure they know it, because they're going to need a muscle biopsy. The number one cause of neuroleptic malignant syndrome is succinylcholine. Do you see it? And the treatment is dantrolene. And yes, you have to know those.
What is dantrolene?
A muscle relaxer.
Okay.
Okay, then you see the next section is regional anesthesia. An example of a regional anesthetic is an epidural or a spinal.
Is the same as local? Is that the same? No? I don't know.
I would have said that. It says regional. It tells you what it is. It's an epidural or a spinal. Now, they tried to be funny, y'all. They tried to call the spinal a subarachnoid block because they know too many people were saying, I don't want no spinal. I don't want no spinal. So they called it some different shit. Subarachnoid block, and don't nobody know what that is. But you do. You now know that's a spinal. Okay? So don't be silly. Do you see the preload? Everybody see the preload?
Yes.
Okay. Now, you didn't give that patient all that water. You better empty that bladder like we said before. It talks about the number one side effect is hypotension. The next list of anesthesia options is called MAC. That is what we have at my job, but it's very different from Twilight. Please make sure you know it's different from Twilight. They are not the same. Your patient is completely confused because they come in and they can't believe they're not finna be asleep. I'm like, no, you signed up for Twilight. I thought y'all put me to sleep. Nope, not unless you ask for it. And the only way to ask for it is to say MAC. all capital letters, MAC. So monitored anesthesia care means anesthesiologist is going to take care of you and put you to sleep. They're going to use propofol and probably those other meds with it. But if it's twilight, please put this in your margin. If it's twilight, it's not going to be propofol. Propofol puts you to sleep. Propofol puts you to sleep. You gotta know that. If it's twilight, it's simply IV sedation done by the nurse. If it's propofol, it's done by the anesthesiologist. And you are going to sleep.
Are you sleeping for both?
Hmm?
Are you sleeping for Twilight? No.
You just in like a dreamy sleep. I mean,
You might fall asleep because you're tired, but you can hear us. Remember, conscious sedation. Do you see the word conscious sedation, everybody? That's different from MAC. That's your twilight. So they may be sedated, but they can still reply to my demands. Then we have the PCA. Woo-wee. Make sure you know 2 nurses must check this. 2 nurses must check the calculations of the PCA.